I'm Arthur Sweetman. I'm an economist at McMaster University, and I hold something called the Ontario Research Chair in Health Human Resources. And it's my pleasure to moderate the second panel. And I think the panelists now have to hit a high standard because the first panel was excellent. But I think we have the right three people to help us hit that high standard a second time. What we're going to do, we have Hannah Maxey and Katherine Zagrodney. Hannah is up first. She's an associate professor and director at the Indiana School of Medicine and Bowen Center for Health Workforce and Policy, Health Workforce Research and Policy. And I think she's up first to talk to us about better interprofessional and EDIA data collection. Hannah.
Thank you so much, Arthur. I'm going to go ahead and share my slides. I'm delighted to be with you today, hailing from Indiana, where I have two roles. Thank you for the introduction, at Indiana University, where I direct a research center focused on health workforce policy. And the work I'll be talking about today, I did want to clarify up front, I did through my consulting entity, Veritas Health Solutions. So my slides are not branded because I wear two hats, and wanted to make it clear those different roles. Today's objectives, I'm going to provide a project background on a new cross-profession minimum data set tool for healthcare regulators that was developed as part of a 2-year project here in the United States, and was a national initiative. Very excited to share that with you today. And then close us with sharing the latest resources to support implementation by states or jurisdictions that are interested in the tool, and highlight resources, and finally end it with results from an early adopter state here in the United States. So I want to start with where this work started. And I, of course, hail from Indiana. And so what you're looking at on the slide right now is a picture or a map of the state of Indiana from 2009. And for those of you that are from the United States, this is our dental health professional shortage area map. So these are federal designations that target dental professionals and help states and jurisdictions and the federal government allocate resources appropriately. In 2009, in my home state, we had very few jurisdictions or counties identified as having shortages of dental professionals. Through state-level engagement of stakeholders, dental professionals themselves, and public health experts, it was identified that health workforce data gaps were the barrier to identifying where we had shortages. Fast forward to 2019, in the state of Indiana, the healthcare regulatory entity, which is the Indiana Professional Licensing Agency, an umbrella agency in our state under which our health professions boards are housed, championed the collection of health workforce data at the time of license renewal from healthcare professionals. Those included dental licensees, medical licensees, nursing licensees, behavioral health licensees, so on and so forth. In 2018, Indiana implemented statutory authority, enabling the licensing and regulatory entity to collect that data during the license renewal process. The collection of that data transformed the way Indiana is able to identify its workforce shortages. And so what you're looking at is just a decade later map. The green areas and the pink area, those at that time were designated as having federally recognized shortages of dental professionals. There was no difference really in our workforce. The difference was health workforce data. So fast forward to 2020 and 2021, and I had the great opportunity to start beating the drum regarding regulators serving as champions for health workforce data collection within states and jurisdictions. One of the presentations that I gave at an international forum was heard by a group of healthcare regulatory CEOs. And so you'll see on the screen those organizations which happen to hear about my work to advance regulators as champions for workforce data collection. These organizations came together in 2021 to look at the issue of workforce data and identify how they, as national healthcare regulatory associations, might support and advance workforce data collection. I had the opportunity to consult with these entities and work on this specific initiative. And it was a year-long initiative. During this project, the CEOs of all of those organizations were engaged in key informant interviews and facilitated discussions to identify what their interest was in workforce data collection and what their thoughts were on how their organizations might support advancing workforce data in states and jurisdictions. They each of the organizations appointed a delegate to serve on a task force that ended up becoming the working group for this project. That working group identified survey tools. I'm going to go into what those were, reviewed research findings from the survey tools that were identified, and prepared a list of core common data elements that exist across all of the different profession survey tools, including federal tools and other types of resources. And ultimately, they prepared a solution. I want to briefly outline the research process that was used as part of the development of the cross-profession minimum data set tool. Detailed review of 15 profession-specific survey tools was accomplished as part of this. So I will say up front that this project included the professions that were listed, including medicine. The Federation of State Boards of Medicine was involved in the initiative. And so therefore the tools related to medicine and physicians were also included in part of it. The tools that were reviewed, of course, here in the United States, our Health Services Resources Administration has minimum data set survey tools that are endorsed and available on their website. So those were reviewed in addition to profession and trade association endorsed or utilized survey tools as part of their workforce data collection initiative. The next step was a systematic identification of the core common data elements that existed and the associated questions across all of those tools. And so I have listed here the core common data elements that were identified. The key findings from this process were that nearly all of the tools had included the core common data elements, but that there was a significant lack of consistency in the core common data elements, both the questions, the response options, and the structures across the tools. Notable for the discussion today is that some of these inconsistencies were even in variables for demographics, such as race and ethnicity, data points and data elements that are absolutely required if we are going to do work in identifying our opportunities to increase representation in the workforce and set benchmarks. Ultimately, the opportunity was identified to develop a consensus tool for those core common data elements. What you're looking at on this screen is the cross-profession minimum data set. And this was developed by those organizations through research and collaboration. It includes 18 questions that were consensus questions that may serve as a framework for states or jurisdictions to collect the core common data elements. If you have a phone and you're sitting at your computer or you're there in person, you can scan the QR. It'll take you right to the CPMDS. In addition to the 18 questions, there is a 6-question supplement, and I want to briefly share about that. So this group that came together, of course, represents different healthcare regulatory boards of different professions, and each of which have different insights, values, and cultures. There was significant discussion regarding, for example, demographic questions and what would be considered the minimum necessary demographic questions to support state or jurisdictional planning, policy development, and evaluation. Significant conversation went into that, especially with regards to demographics. It was determined by these organizations that the CPMDS itself would include a very brief list of demographic questions, but the supplement offers additional questions for jurisdictions or professions that would like to have an expanded offering of demographic data collection. So here are some of the CPMDS values and innovations. The first is that it enables cross-profession comparison. So the existing survey tools right now and resources, unfortunately, without the consistency, there is no ability for cross-profession comparisons. The other is comparisons with the population. So some of the work that was done in the development of the CPMDS that I just don't have the time to outline here today was that there was great care taken to look at population level surveys that gather population data here in the United States. For example, the American Community Survey of the US Census Bureau. And so aligning the cross-profession minimum data set core common data elements with population level data collection and management strategies, it enables comparisons of the workforce with the population at a higher resolution that may be available currently. Also, cross-jurisdictional analyses. So states frequently want to compare themselves to other states, or jurisdictions may want to compare themselves with other jurisdictions. Unless we're using the same measuring stick, we really don't have the ability to do that. So this enables those types of comparisons. Also, a top value, of course, because this is healthcare regulatory entities that spearheaded this, was the support that could be provided to state and jurisdictional entities through implementation of this tool. So, obviously, shortage identification, workforce shortage identification, which here in the United States, we know in part through our federal designations is the HPSAs, the medically underserved area designations, and now we, of course, have the MCTA, or maternity care target area designations as well. Assessments and evaluations. So we have other professions that are outside of those federal designations that we still need to do assessments on. And also, there's frequently a need to evaluate the policies and programs that are implemented within states and jurisdictions in order to inform appropriations through legislative entities, and also, quite frankly, just for program improvement. And then finally, decision-making obviously is a key value. I think the innovation in this tool is the CPMDS serves as a framework for standardization. And I want to explain, it isn't a drag and drop completely. So it offers a framework for standardization with 3 levels of standardization across the tool. The first is standardized question with standardized response option. Demographic variables and questions within the CPMDS, for example, are all standard response, standard question. They should be consistent across professions and across jurisdictions. There is a need, of course, for variations by profession in certain core common data elements. For example, specialty, setting, various practice characteristics, even education, where we have varying education levels for entry and varying highest levels of education that certain professions may have. So for those questions, standardized questions are offered with either mappable response options or completely flexible response options. The innovation is, though, by having standardized questions in those, and either mappable responses or flexible responses, it still enables some level of comparison and cross-profession comparison to be done. So as opposed to a drag and drop survey tool, it has some drag and drop, and then others that there's opportunity for customization and flexibility. In addition to creating the CPMDS, great care was taken to create a implementation tool. So very frequently as researchers, we will develop and identify new knowledge and innovations, but translating those into action with the individuals either in decision-making authority or those that have the ability to implement is critically important. And so in order to support implementation within states or jurisdictions by healthcare regulatory boards or agencies, a roadmap was created that offers step-by-step guidance with decision points where individuals might consider different options. And so I would encourage you to check out the QR code if you're interested in that. And I think the slides will be shared with you post-meeting. I want to end it today with how it's going. So I shared the story from Indiana starting in 2009, when as a young master's student, I became very interested in workforce shortages and workforce data. The state of Utah happened to be at a meeting in late 2022 and heard a presentation that I was giving to a national healthcare regulatory board convening on the cross-profession minimum data set. The state of Utah stepped forward and said that they would like to pilot the cross-profession minimum data set and did just that in 2023. What you're looking at is, with the permission of the Utah Office of Professional Licensure Review, the pilot findings of the implementation of the CPMDS with their behavioral health boards. I know that many of us are researchers. We're all here to talk about workforce data. So the cliff notes are, they had over 16,000 active behavioral health licenses in the state. And at the end of the day, by implementing the CPMDS, they were able to identify that, in fact, they had just over 5,600 actual patient care full-time equivalencies practicing in their state. That data helped to inform conversations that have ultimately led to legislation that is anticipated for the 2024 session in Utah. So this is just exemplifying the value of implementing this type of data tool. And with that, I am happy to connect. I think we're going to hold questions till the end, and I will hand it back over to you, Arthur.
Thank you very much. That was great. We have a minute. If anyone has a burning question or a question of clarification, we can handle one or two now if you want. There might not be, but just if there was any burning question or question of clarification. Okay, we'll leave the big questions till later. And so then we turn now to Katherine Zagrodney, who is at the University of Toronto and is also with the Canadian Health Workforce Network. Katherine. She's going to give us something about the Canadian case and the efforts that we're taking right now to try to develop a larger, bigger minimum data set. We have like the US, a very decentralized country. My view is Australia, although it's a federation, is a more centralized federation. We have a very decentralized federation. It leads to all kinds of problems. Here the slides are up.
I agree, Arthur, and that's what I was thinking as I was listening to Hannah's excellent presentation. Hi, everyone. I'm happy to be presenting today on behalf of Canadian Health Workforce Network's Minimum Data Standard team. Although I'm the one presenting the work, what I'm speaking about is a combined effort with input from many others, including many in the hybrid space today. The project lead is Dr. Avi Bourgeau, with funding from the Canadian Institutes of Health Research. In this presentation, I'll briefly describe the current state of health workforce data in Canada, which Arthur just alluded to. Then I will spend most of my time describing the process which we undertook to co-develop an inclusive and integrated health workforce minimum data standard, purpose-built for planning in Canada. And I think you'll see some overlap with what Hannah presented. So diving right in, I'll very, very quickly provide some information about the way many healthcare services are delivered in Canada, in case people are just joining and who are unfamiliar. So Canada has a decentralized healthcare system wherein provinces and territories receive federal public funding and were granted the responsibilities for delivering universal healthcare. The division of responsibilities between government levels is highly political. Many healthcare occupations are formally regulated through regulatory colleges, which generally have their own set of requirements by province and territory. Health workforce data collection is similarly complex and multi-layered. The major sources of health workforce data in Canada include, first, provincial or territorial level regulatory college data, and second, federal level surveys conducted by Statistics Canada, wherein healthcare workers are typically identified within larger surveys or census data. So the majority of both of those sources are not collected with the primary purpose of healthcare workforce planning. And there is no uniform use of single minimum data standard for health workforce planning, which leads to some challenges. Those would include differences in the information collected across healthcare occupations or provinces and territories, differences in the definitions for data elements, similar to the US, and in some cases, even variations in how an occupation is defined. Another challenge is the lack of or appropriate collection of equity data, in some cases, making it impossible to track key equity dimensions within the healthcare workforce. I'll also note data collectors have varying degrees of responsibilities and powers. The legality of sharing data can also be a barrier to accessing data and can limit the ability to combine across existing sources. Overall, health workforce data in Canada is currently siloed, and it's difficult to compare across occupations, by geographies, or over time. Skip ahead once here. Second, there we go. So where should Canada go from here? I think everyone in this virtual and physical space is aware of how important it is to have high quality health workforce data. That enables us to do complex analyses and modeling, which help to inform policy and planning. Several countries with representations in this room have accomplished more cohesive interdisciplinary data tools for planning based on a solid foundation of standardized data following a minimum data standard. To catch up with other countries, Canada would need to start from the ground up and build infrastructure that maps data elements needed through an integrated and national data strategy and minimum data standard. Generating a standard that is specific to the context of Canada and that includes stakeholder input is important for successful implementation, similar to what Hannah said earlier in the US. In order to have stakeholder buy-in, for instance, to have regulatory colleges choosing to follow a standard when collecting data, their involvement in the creation of a standard and input into what and how data elements should be collected is paramount. At CHWN, so the Canadian Health Workforce Network, we sought to address this challenge by developing an integrated and enhanced minimum data standard for health workforce planning. Our goal was to design a practical, co-designed standard with application across a range of healthcare worker groups. Following the International Standard Classification of Occupations definition, we chose exemplar case studies from a range of formally regulated and unregulated healthcare occupations. The resulting 11 case studies represent a variety of professional practice opportunities and sectors. The degree of existing sophistication in data collection and reporting by case study varies along a continuum that is shown here. This allows us to understand how groups with differing levels of existing data are able to utilize the standard. The project team was then formed to encompass expertise across each of the occupations as case studies. There were 3 phases in the development of our minimum data standard. I'll provide an overview of the process here, and then I'll describe each phase in a bit more detail in my next slides. First, our team gathered existing minimum data standards and synthesized the data elements across existing standards. A scan of international health workforce literature was also conducted to identify any potential new data elements that were not included in those existing standards. In phase 2, we had stakeholder online dialogues where we gathered input on suitability of the drafted standard and its ability to collect necessary data to answer key planning questions. And those stakeholders included healthcare workers, employers, unions, government representatives, etc. In the third phase, we worked our way backward from the data elements that would be needed in a theoretical planning process to review our drafted standard against our original intent of generating a standard that would allow for better health workforce analyses for planning. In phase 1, minimum data standards from WHO, APRA, HRSA, CHI, and HPDB were reviewed and synthesized in particular. These were the main ones that we focused on. Next, a literature review scan helped to verify that data elements listed in existing standards were actually utilized in research and analyses. We also used that scan to augment data elements in existing standards. Any data elements commonly used in research in this area, but not included in reviewed standards, were then considered for inclusion. For example, data elements around pay were not in reviewed standards, but were commonly used in research relevant to health workforce planning. At the end of phase 1, a draft standard was developed. We used Excel. It was all encompassing of data elements from these past standards and the literature. This was not yet a minimum standard. It was all inclusive of considered data elements at this stage. Although not originally part of the formal plan for this phase, organically, phase 1 led to the development of a set of principles which our team used throughout the next stages to determine whether a data element should be included in the minimum data standard. We discussed the logistics, practicalities, collecting information on this data element, legal and regulatory contexts, and data collection burden. For instance, for data collection burden, the degree of respondent burden expected for a given data element was noted in relation to whether that could be tombstone collected once given data linkages available For example, date of birth was deemed as a low burden data element. You could collect it once and you don't need to ask about it again if given proper data linkages. In the second phase, we gathered input through a series of stakeholder dialogues. By conducting a deliberative dialogue with key stakeholders, this step allowed us to check whether a drafted standard was practical and applicable to the interdisciplinary context, and whether it resonated with stakeholders in this area. Stakeholders included employers, scientists, regulatory authorities, educators, data custodians, unions, and associations representing healthcare workers from our case study groups. As part of this dialogue, a particularly informative activity included breaking up into groups to brainstorm and then bring together our collective top-rated key planning questions and barriers to answering those questions in the current Canadian data landscape. The purpose of this was to then see if our existing drafted data elements would allow for these questions to be answered. For instance, one of the top-rated planning questions was, how well does our profession profile match the patient population in terms of gender, ethnicity, sexual orientation, etc.? A barrier identified to answer that was a lack of consistent and common definitions used when collecting that data and data availability. That feedback allowed us to understand the importance of ensuring that these types of data elements were included in our standard. That was one example, but the main feedback that we received from this phase was in highlighting the importance of adding mental health and scope of practice data elements to the standard. We did not have those specific areas addressed as well as we should have before. It also became evident that data elements related to education may require standardization in the way that they are collected within healthcare work occupations, but that each case study may need different response options. For instance, entry to practice education for physicians may require additional data elements compared to that of nursing. In the third phase, we worked to condense our list of potential data elements into a true minimum data standard that focusing around planning. First, we brought together our project team of experts to undertake a consensus-based decision of which data elements to include. Health workforce planning was used as a touchstone from which to base inclusion decisions. These conversations also link back to our guiding principles developed in phase 1, which I presented before about logistics, legalities, and data collection burden. Secondly, expert members of our team worked backward from the data elements that would be needed in the theoretical planning process. Our process so far was building on existing standards. In this step, our experts did not constrain themselves to what existed previously and considered how data on the patient side could interact with hypothetical health workforce data to enable analyses for planning, similar to what Hannah presented for matching with the population data. At the end of phase 3, we had a streamlined version of our minimum data standard for health workforce planning. In conclusion, our process in developing a minimum data standard for health workforce planning benefited from building on existing standards, an integrated and open consultative process to the development of a standard not only contributed to a more robust standard, but also led to early stakeholder buy-in, which is essential for subsequent planning processes. Practical considerations for data collection are an important aspect of developing a minimum data standard as well. Next steps include working with demonstration projects from the case studies, working out some of the kinks when applying the standard to practical real-world data collection and application. Although in this example, the set of data elements and the minimum data standard was developed with a pan-Canadian context in mind, the process is likely transferable to other countries, and I look forward to comments on it. With that, I'll say goodbye and thanks.
Great. Thank you very much, Katherine. Do we have any sort of questions of clarification or burning questions for Katherine? I see one in the room.
Oh, it's so interesting. I'm just wondering, are you planning in another phase to add more professions to this?
Ivy, if you're in the room, do you want to comment on that?
Yeah, I think the minimum data standard that's being developed can be adopted by all professions. So we have just chosen those specific groups to do sort of a deeper dive. They were chosen quite specifically because, as you know, Katherine noted, there was a range of data quality, right? So even though they're listed as having high quality, all of those professions are still siloed within those higher quality data. So we chose these professions in part because we had a team that could surround it, and that they had particular practice circumstances that we wanted to take into consideration. So just as an example, you know, midwives are often sort of in group practices. Social workers, psychologists are often working both in public and private sector, like those types of permutations. So our hope is that doing these deeper dives is being mindful of being transferable across many different professions. So thank you.
Any other immediate burning questions or questions of clarification? Okay, then I think it's time to move on to our third speaker before we have a broader open discussion. So the third speaker is Tina Kunjaman from the Data, Evidence, and Knowledge Management Unit in the Health Workforce Department at the World Health Organization. And she's in a very different time zone, zooming in from Geneva. And with that, I turn it over to Tina.
Right. Thank you. Thank you for having me and inviting me to the panel. And it was excellent to hear from the panelists before me on what's happening on ground. With this presentation on the National Health Workforce Accounts, I'm going to take you maybe 1 or 2 notches at a global level and explain what we're doing in WHO with the National Health Workforce Accounts to help build capacity in countries, to help build capacity to strengthen their health information systems, and how this is done in a standardized manner. So this all started with the global call, the SDG era, moving from the MDG to the SDG and the World Health Resolutions, and the several pandemics that have hit us. The member states required or mandated WHO to have a reporting by which we would be able to know what is happening with the global health workforce. It wasn't enough to just know at the national level, but also to know with migration, mobility, and the labor market flows, what is going on in the world and what is the situation of the health workforce. So why would the global call for data and the importance, why is the health workforce data so important? So the data and the National Health Workforce Accounts, which I'm going to dive into shortly, the National Health Workforce Accounts could be data, which would then feed into dialogue. Dialogue meaning you could use the data for a health workforce planning or a labor market analysis, or to understand what are your production plans and your capacities, which then goes into decisions. And then it ends with an investment. That's the last D, which is the dollar, right? But in WHO, we want to say that it's not enough to just go there, always come back to the data. And this is the approach with the NHWA to say that's an iterative process. And I'm sure my co-panelists agree that this is never a one-off. It's done and it has to be reviewed, and with a multi-sectoral, multi-stakeholder governance mechanism put in place to ensure that this process actually yields good effect. So what is NHWA? So NHWA, the National Health Workforce Accounts, is a system by which the countries can progressively improve their health information systems data in terms of data availability, data quality, and even the use of health workforce for planning. Eventually having the data to understand, are they even meeting their health objectives that the national or the country has set out? Now, the NHWA, if you're familiar with the graphics on the right, that's the health labor market framework. The health labor market framework deals with the pre-service sector, which is the ones in orange you see there, the education sector, then the labor market itself, the ones in blue, and then the retention, the governance policies. So the NHWA goes through the labor market frameworks, and what we try to achieve is in core principles of NHWA, and I've heard my panelists, the co-panelists, speak about the same, is to ensure that there is a multi-sectoral governance in whatever happens, as in the decisions taken to improve data should include all relevant stakeholders. One thing we insist on countries is when we go into country support, we often find countries saying, oh, we don't have the data. And we tell them, maybe you don't have a technology solution or an HRHIS that you think is up to mark, very comparable with other countries, but there is data. There is often data, it's siloed, it's pocketed, it's never shared. So we want to build on the diversification of data sources, which could be a Ministry of Health, it could be your professional registries, it could be your census data, it could be your labor force survey data. So diversification of data sources, and together a system strengthening approach. And in the NHWA, we in WHO put the countries first. So I guess, as in WHO, you have, let's say, a range of countries where some are pretty advanced with your health workforce planning, with your data capacity, while others are in a different, in a totally different capacity. So here we tell the countries and the countries' needs first, and we provide NHWA in a way that the data can be used to analyze and the culture to use data to not just report, but the data should be used to inform decisions and make policy. That's the idea with the NHWA. That's one of the core principles. Now, like I said, the resolution mandated all member states to report to WHO, so WHO could make this NHWA data as a global public health good, and then create evidence and analysis and scientific studies to show what is happening around the world. The way we wanted to do it, and this is where we wanted it to be different, we didn't want it to be another reporting burden to the country. What we've developed, and I'll show you the tools and guides, is to create this platform, the NHWA data platform, by which countries use it if needed as their own mini health information system, with transparency at the national, regional, and the global level. And so you have one point of truth across the 3 levels of WHO, if you may, with the ministries of health. Strategic approaches that we use for implementing is standardization of indicators. You can imagine if you're working with one country and a federal system, there is a need to standardize between indicators to be able to have systems that are interoperable. So all the more the reason to have a set of indicators that the countries could look up to build their information systems upon. So we have a minimum data set. We built the NHWA on the minimum data set, which Katherine referred to in her presentation. We developed a set of tools and guidelines so that countries could follow a common methodology. We built capacities with workshops, which we continue to do. 5 years down the line, we've just launched our version 2 of the NHWA, which is a more streamlined, building on experiences from the last 5 years, and technical support to countries. And that's how, as WHO, we go into the countries and the regional levels to improve their capacity to use data, to collect data, and strengthen their health information systems. Now, going a little bit into some of the practical steps, I'm not going to dwell into detail. I'll leave the reference there for you to look at. What I want us to take attention here is what we've seen in countries is sometimes you do have a good system, but without good governance. Or there is just a governance and there isn't a legal framework. So this is a system, or this implementation takes the country step by step to say you need to have governance, you need to bring all your stakeholders together, you need to use the data and make sure there are good MOUs and legal protections for your data so it can be used in a responsible manner. And it's yielded well, I must say, and countries are in different phases depending on their capacity and their priority. They go through the different steps to yield a good implementation process. The next guidance or the tool that we have is a handbook. What you see on the top right is, again, the labor market framework. And the whole handbook is, this is the version 2. The version 2 is a more streamlined, capsulated form of the version 1 based on what we've learned and what we've heard from countries. We have a module on stock and flow, so a set of indicators or data elements that would help a country to identify or know what's happening with their labor market stocks and flows. There is a module on education, which talks about where your bottlenecks are. Do you have enough production? Do you have enough applicants? Do you have enough teaching capacity? What is happening in the education aspects? And the finance and expenditure, and the last one on working conditions, governance, and leaderships. How do we standardize this? So I thought it might be interesting for this presentation so that's how it looks. One indicator, you have the name, a data element, the numerator, denominator, the disaggregations possible that we require of the countries. So what we recommend is this is the disaggregation you need if you want to make a reasonable health workforce plan. And then we go into even providing what are the potential data sources and guidance and a glossary, etc. The next standardized tool, and I find this very, very interesting when I work with countries, is the health occupations. Health occupations are so the same and not the same. Why do I say that? You can have a same title, but two different, you'd have different regulatory systems which allow you to practice differently or do some in some countries, and those are not allowed in other countries. So at the global level, what we really encourage countries is that they have their national classification of occupations, which we call the NCOs, which are much, much detailed. But then when it comes to reporting to WHO, for purposes of global regional comparison, that we map to the international standard classification of occupations. So for those of you who know, ISCO is maintained by the ILO. So we in the Health Workforce Department, we work very closely with the ILO. We're working with them they're working to their revision of this ISCO, the 2008. We're hoping to have a new revised version in 2028. So currently we're in the consultation processes with the member states. And so the idea is to develop a list of occupations that reflect the health occupations very well at the international level. So I'm sorry if you can't read that, but that's for you, the health occupations, the 50 odd or so that we're collecting globally through the NHWA data platform. Where are we today, 5 years down the line with the NHWA? We have over 184 countries that have NHWA focal points. These focal points are responsible to report their health workforce data, the NHWA indicators, through this common platform that I'd mentioned earlier. This is the data that goes into the SDG 3C1. I know that some of you are familiar with the NHWA data portal as well. Like I said, the idea for the NHWA was not just to have an Excel sheet with reporting burden to countries and nothing ever comes of it. The idea, and this is really upon us as WHO, we have taken that once we've built capacity in countries and the data is shared, we use the data and convert that into a global public health good. And so we've released several studies, papers that talk about different aspects. We've worked with different partners and authors around the world to create more information and knowledge on health workforce. And before I go into my last few sets of slides now, I just thought it might be interesting to see what we've managed with all the data that has come up through the last 5 years. So if you remember, the Global Strategy 2030 said we had, 14 million, we're going to have a 14 million health worker shortage by 2020. Now, with the data that's come in through the NHWA with revised and more recent data, more updated data, we see that that has gone down to 10 million. That seems good that, you have now the shortage has gone down to 10 million, but then you look at what's happening at the region. What's happening, that's a global level stats, but what's happening in the region? You see that CRO, which has a 45% shortage in 2013 estimated, goes down to significantly goes down by 2030. And here you see where countries, you can imagine, so apologies, those are WHO acronyms there. CRO is the Southeast Asian region for WHO. And we know that many countries in that region have a younger population. So we see how population drives the shortage, how population would actually affect. So we're beginning to look at the aging aspect of the health workforce and the aging aspect of the population as well. I also want you to, pay some more attention there. We see AFRO, which is our African regional office in the countries within those. They actually have increased the number of health workers. But what happens is the shortage doubles. And this again goes down to say, what is the burden in the country? And so what we see at the global level is it's not enough to do some global estimates when you go down to the region, and even more so when you go down to the national. Let's look at what happens in some of the countries. So you look at the top 10 countries in absolute numbers, you have the high population countries, right? On the, I don't think I've got my pointer here, but the first bars, you see Nigeria, Pakistan, Bangladesh, Ethiopia. So these are the countries which are densely populated. You see that the absolute numbers and the shortages they create, they're on top of the list. But if you look in the center, these are the small island developing countries. It's a totally different list of countries. And the shortage, say, in Haiti or Papua New Guinea and Dominican Republic, for those countries, this is immense. Go to the last one. And these, again, you see that they are not countries that came in the previous, but here we're looking at the relative. We're not looking at absolute numbers. We're looking at relative shortages. And you see countries like Niger, Somalia, Chad, they have to increase their health workforce 10 times to be able to in a way mitigate the shortage. And this is not something some of these countries will be able to achieve. So what are we going to do at the global level? What are these countries going to face? And this is not talking about the issues of migration, circular migration, labor market flows, or production capacities, just looking at the stock there. But I believe this is my last slide. So yes, we do have a lot of studies that we do at the global level, but we encourage countries to use this data for the planning. And we've seen in countries like Ghana and PNG, they've actually gone ahead, done their NHWA, improved their health systems awareness, health workforce data awareness within the health systems, and really gone ahead to, in PNG, I think this year they've opened up so many new posts and they are recruiting. They did come to realize with their health labor market analysis that actually they do have graduates who are not employed. So while they have a shortage, they do have unemployed health workers. So they've put in mechanisms to policies in place to improve the situation health workforce wise and to improve the health service delivery. I think that's my last slide, and I hope I've kept within the time.
Thank you very much. That was great. Before we turn to broad general questions, are there any burning or questions of clarification for Tina? No? Okay, well, I'm going to open up the floor then for broad general questions. And, oh, I see one hand up already. So Ivy is channeling all the people online. So Ivy.
I'm channeling myself and all the people online.
Okay,
so there's one question that I'm going to pose to both Tina and Hannah. And, you both identified implementation as being a really important issue. And one element of implementation is, having a license, like in a licensing agreement to be able to utilize your minimum data standard. So Hannah, I'm going to ask whether there are any licensing agreements that the regulatory authorities have to enter into in order to use the minimum data standard that you've developed. Tina, similarly, is there a licensing agreement that like the different countries utilizing the WHO minimum data standard or the National Health Workforce Accounts? So when they want to use that and the guidance, is there a licensing agreement that countries need to enter into for that? And then I have a question for Katherine that's online, but I'll come back to that after Hannah and Tina. Over to you.
Thank you for your question, Ivy. So the very short answer is no, there's no licensing requirements. Those regulatory entities sponsored by the Healthcare Regulatory Research Institute wants to promote the cross-profession minimum data set tool freely and publicly accessible and available for states and jurisdictions to implement. So I shared the direct link that is freely and publicly accessible, made available by the sponsor.
Thanks, Hannah. Tina?
Yeah, I think I just have to say ditto. There is no licensing agreement, or there isn't a need to request licensing from WHO. The way WHO operates, everything that WHO publishes is a global public good. What we do with countries when they ask us to help them with their NHW implementation is we go in, we provide them a full-fledged training on how to read the minimum data sets, how to develop their indicators, how to collect the data. But there isn't any licensing agreement with WHO. What we encourage countries is to have memorandum of understanding or a legal drafted document that allows the different stakeholders in the country to share data among themselves, because this is something we've seen, and I guess we all understand, in some countries, in many countries, data is power and it's not often freely shared. And this is where we say, okay, that's your data, but then this is a legal framework by which for the country. So we help them draft, or we advise them to draft a legal framework for internal data sharing purposes.
Thank you.
Thank you.
So I think you have one for Katherine.
I have also, yeah, so one for Katherine, but I think Hannah or Tina, you could probably also address this broader question, but from a colleague from Quebec, André Garapi, asked Katherine, are you aware of a jurisdiction in Canada that is lacking sufficient workforce data to do even proper planning within its own health system? And if so, what are the issues? Is it capacity? Is it collaboration amongst stakeholders, et cetera? And I suspect, Hannah, you could also probably speak to that, of different states, and Tina, of different WHO countries. So Katherine, over to you first.
Thanks. All right, I'll try not to take up too much time because I could probably speak to this for a long time. Thanks for this question. So there are many examples of workforce data that's insufficient for planning across Canada and in specific jurisdictions. One example, most provinces do not even have headcounts for personal support workers, healthcare aides. They have different titles, but they don't even have headcounts, never mind more information about full-time equivalencies, age of the workforce to predict retirement, etc. Ontario is one example that is limited here, but most provinces don't capture that type of information, and that's a large healthcare occupation. I know data for providers of mental health also lack the detailed data that, say, nurses and physicians tend to have a bit more. But even there, data for physicians, medicine is generally more detailed, but even there have been discrepancies in the numbers, the headcount of general practitioners and the age of GPs reported between COPS, so Statistics Canada data, and CHWN. And so within occupations across provinces, there are so many different examples. And there are a lot of different reasons why this is a challenge. For my example with personal support workers, they do not have a regulated college, so that's one source of data that's lacking, and it is difficult to collect data on that workforce. And the way that Statistics Canada defines PSWs isn't perfect either. So those are some of the challenges there. Capacity is a challenge, and also just there isn't a strong health workforce plan within many jurisdictions, which will help guide improvements in this area. The way that data is collected is often not intended for health workforce planning, so it's not a surprise that it's insufficient to do so. That limits the usability of the data. If data followed a standard, for instance, a minimum data standard that was intended for planning, that would be one way that I think we could start to address some of those challenges. But thanks for the question. I could go on and on. I think that's the shortest I can respond. Thanks.
Okay, I think we have one more question online, but oh, sorry, do we have another answer for that question?
I'm happy to take it. So here's the deal. I work with a lot of states, so I don't want to start naming states that I think have great opportunities to enhance their work. I would rather focus it on that a month ago, I was at a convening of all 50 states and their regulatory boards for single occupation. And I had the opportunity to give a keynote on the CPMDS tool at that event. And I opened the event with a question and asked, as of today, if your governor came to you and said, how many X licensees are practicing and providing direct patient care services to residents of our state, either in person or remotely, are you able to answer that? Less than half indicated that as of today, if their governor asked them for that, they could answer. And so that should be a barometer of the opportunities across states to identify just very quickly, we have our licenses, but what is our actual capacity? So that was kind of sidestepping which states are not, maybe doing the best or have the greatest opportunity, but I can tell you many.
Thank you. Tina, did you have anything you wanted to add to that?
Yeah, I'm just going to touch on what Hannah and Katherine actually mentioned, that it is an issue when it comes to data availability for, so quite often you find the occupations that have regulatory bodies, they do have some kind of data because they need to have it recorded. But for those that are once licensed and don't have a relicensing, the mechanisms are not in place. And coming to what Hannah was saying, it's just that you're licensed, but are you even in the country? Are you even practicing? You've started your own business, you're maybe into catering, but you're there and you're counted. So is the country or the governance or the body going to count on you for health services? So in the NHW handbook, we have an indicator that goes your head counts by activity level, and we divide them as licensing, professionally active, and practicing. And we always encourage countries to go to the practicing health workforce as their active health workforce for all health workforce planning. But this is a challenge in many countries.
Yeah. Thank you. Maybe I can just add to that, since I have a pet peeve on this. In Canada, we're pretty good at separating out who's licensed versus who's practicing, but we're very bad at measuring the degree to which they're practicing, full-time, part-time, how many hours a week. And there are big trends in labor supply by an individual over time. And we're not very good at dealing with that in our planning. So I wanted, if I'm going to intervene, I'd say one question. Let me just, before we do that, I have one question I want to put. I'm going to abuse my position here. The title of the session is Better Interprofessional and EDIA Data Collection. I didn't actually hear very much discussion at all about the EDIA part of the title. And I'm wondering if I could impose on the three speakers to talk about what they're doing around equity, diversity, inclusion, and accessibility in terms of the minimum data sets. How can we build minimum data sets, minimum data standards that help us to think about inclusion, to think about equity, to think about diversity within the healthcare workforce? So it struck me that it's in our mandate, and we didn't really touch on it very much. So I'd like to see if the three have any comments on that. Anyone want to go first?
It seems like, yeah, I'll go first. I'll go first, because I guess there is no golden answer. There isn't a bullet answer to this. But with data, it's just improving the data. So you start off with what you got, then you see where your blanks are, and then you improve. So equity can be measured as in gender equity. You have equity even in your age distribution. We're seeing countries with an aging workforce. They don't have enough nurses in the production. So equity is not just about male, female, which many people think, or even sub-regional and even country. So equity has to be measured across all the disaggregations, as we call it in NHWA, be it age, be it foreign born, foreign trained. I mean, basically, equity has to give you an idea whether you have the right kind of health workforce for the kind of health services that you want to provide to your population. So I'll stop at equity. Diversity is not something we deal a lot, but I know at the country level that is also something. Diversity, ethnicity, or other aspects also come into play.
Well, thank you. Does Katherine or Hannah have anything to say on the EDI side?
I can make a comment. So we do have expertise on our team from researchers that have a specific expertise in collecting data on gender, ethnicity, or race, and indigenous data. We also heard from our stakeholders that was an important piece to collect and to compare to our population, our patients. I'll say that some roadblocks, sometimes people, some comments that we received is that it can never be perfect. It's always moving on how to collect this type of data. And I think that's not a reason to not collect it. You need to start somewhere, but it'll probably be more of an evergreen, how to collect gender appropriately will always be changing, for instance.
And Hannah?
So this was greatly discussed in the development of the cross-profession minimum data set tool with regards to demographic characteristics. And the consensus among that group was that demographic data, which can help states, jurisdictions, researchers understand the characteristics of the workforce to compare the workforce to the population, to do studies, set benchmarks, develop policies and programs to advance equity and diversity within the workforce. There has to be a framework for collecting that data. And so there was a lot of discussion about that. And in this group, it was decided to mirror population data that are collected to enable those comparisons to the population. I think that was probably like the biggest thing, because this is the development of a tool. What I will also say is equity in data collection across professions, because you'll frequently have the 800-pound gorillas. Okay. Well, I'm sorry, that was probably a bad term, but like the physicians, the nurses, right? They're the big workforces that everybody wants to talk about all the time. But there are others that are critically important. And I think that we, as a population, at least in the United States, have really identified that some of those more direct entry and middle skills workforces are absolutely critical, those that provide long-term services and supports. And so having equitable strategies within a state or jurisdiction to ensure that you're collecting data, not just on the high skills, higher wage occupations, but on the full extent of the workforce, to ensure that you're able to understand that. And I could go on and on about that, but I think it's about ensuring that you're capturing the minimum necessary data to support assessment, evaluation, and planning related to diversity and inclusion. The last thing I will say is, and I put in one of the questions, a link to Indiana's survey tool. So in addition to this CPMDS, I work in the state of Indiana. I work very closely with state government. I oversee all of the surveys that are implemented as part of our licensing processes. And there have been at the governor's level lots of discussion regarding the inclusion, the inclusiveness of our language that we use when we collect data from individuals. So I would encourage you to check out Indiana's tools where they go beyond the CPMDS, which is absolutely appropriate. I think there's a framework that we should get towards standardization. And then, just as Tina said, localities, jurisdictions, they have different needs and unique needs for data and information. And so in Indiana, if you check out some of the language we use, there was a lot of discussion and care towards the inclusivity of the specific language.
I find that last point really interesting. I think that was very helpful. So thank you very much. So I think we have some people in the room who have questions. I think I had Margaret first, and then I don't know your name. Sorry. Anya second, and Steve third. Maybe is there another person? Maybe we can do those three. Oh, then maybe. Sorry, what's your name? Gail. We'll do Gail fourth, and then we'll go back online again, if that's okay. Margaret.
Great. Thank you so much for the presentations. Just a couple questions, but one for Hannah. When you saw Katherine discuss the way in the kind of stakeholder negotiations that were involved in the creation of that MDS, was that similar to the level of stakeholder engagement that you had? Just that. And then for each of the panelists, I'd be very interested to hear how far they think their data, their MDS and their data engages with the idea of fair. So the notion in scientific data that you should have data that is findable, accessible, interoperable, and reusable. And I know Tina talked very clearly about this on the WHO platform, but I wondered if the other two could just mention how far their data sets meet those fair requirements. Thanks.
I can't speak to FAIR. I'm very sorry. I was not aware of that, but I will look it up after this meeting and I will find out about it. So to be very clear, this CPMDS project is very much governmental or jurisdictional focused. So whereas other initiatives may be driven by researchers or individuals with interests that are outside of government interests, the stakeholder engagement was extremely heavily focused on state or jurisdictional governmental leaders, whether those were regulators, whether those were health commissioners or agency leads, or workforce development or labor agency leads, or even governor's offices. So there was an extensive stakeholdering process, but the focus of that stakeholdering was very much state or jurisdictional entities. And to speak very frankly, that's because I believe that they have the greatest ability to pull levers to gather data in a consistent fashion. And quite frankly, through legislative authority, they have the ability to put it into statute and ensure that it can be collected in a standardized way. So I hope I didn't over answer.
That was perfect. Thank you. Katherine or Tina, do you have any comments on that question?
Sure, I can say my piece. In terms of how findable and accessible the data will be, that is outside, I think, of the standard. That's really the data holders, and we don't have that much power over what that will look like. Of course, we have our own ideas of how we want that to be, but that would require, I think, beyond the project of a minimum data standard. The interoperability was a key piece stressed throughout the project on our team, as you know. The goal was that this data would be interoperable across time, occupations, and geography. Reusable as well falls in that same category. So I think we can address part of the idea of FAIR, but not all of it through this specific project.
Thank you. Tina?
Yeah, I can just quickly say that it was one of the things that we've always considered, given that we as WHO do not have the resources in countries, we cannot burden the countries too much. As I alluded, the platform is a transparent platform wherein all stakeholders can see what data is there at any point in time. This is up to the country to decide who gets to see which data. That's the way the architecture of the platform is such that WHO and the country focal points get to see the data. Reusable, yes, it is reusable, and that's where the handbook comes in place. We have the indicators and the metadata, hence making it interoperable. We're working with some countries to even get data in through APIs and build their systems to be able to configure an automated data flow from their information system to ours. And we're getting there step by step. And we find that with the research and the studies we do, we're able to replicate the 2013 studies with more recent data. And so, yes, the data is reusable. So I think we can probably say that's one thing that we're doing well. This is to say at the WHO side, but yes, at the countries, the systems are still they're in different levels of maturity.
Thank you. So we're going to turn to Anya, your question.
Yeah. Hi. I am not a researcher. I work at the Ottawa Hospital as a EDI coordinator. So I'm coming from a different perspective, and forgive me if this is out of scope, but I really appreciate the work of standardizing indicators. That's something that's crucially needed from a health workforce planning need. We at the Ottawa Hospital are looking at how do we ethically collect and use socioeconomic demographic data for the purposes of addressing inequities for our patients in the community we serve. I think from an operational struggles that I'm talking about here, explaining the value of collecting that data to the patients, I think is a barrier. There's a lack of trust about what you're going to do with that data. Data quality is also very messy. And so I think before we even start collecting, I think we really need to answer the why we're collecting specifically socioeconomic demographic data, because there can be a fear of being labeled and lack of trust about maybe retaliation or retribution by being known as being maybe in an equity deserving group. So yeah, I'm more of an operational question out of scope, but from a data collection and use perspective regarding EDIA, any guidance on that?
I think data should never be collected for the purpose of just having data. And so I think it's critically important that whoever is collecting the data has some upfront, this is the purpose and intention of this, whether it is to understand the demographics of our licensed healthcare workforce and how they compare to the patients and populations they serve, so that we can design strategies to enhance diversity in the workforce, or whether it is we're collecting this data so that we can assess and monitor outcomes of patients of certain demographic characteristics and the relation and relationships with providers of varying demographic characteristics. I think there needs to be a statement upfront whenever such data are collected, and it needs to be clear and it needs to be shared with individuals at their literacy level, which I do think we sometimes have challenges with doing.
That, can I just intervene? How does that go with the reusable idea we talked about a few minutes ago? Because there is a real issue that much of the data we're talking about is not single purpose. It is reusable. And in that case, identifying that type of cause becomes more challenging. So how do you square that circle?
Probably through transparency in something such as these data will be used to support workforce assessments and ensure competency of care among our workforce for people of all populations, races, creeds, demographics. Like, I think you should have in mind the questions. And actually, if you go into the roadmap, it literally walks states or jurisdictions through how states should actually think about the data they need so that they have the value proposition up front. But I think simplifying it at the appropriate level that enables the use for the appropriate items or questions, I think it can be framed. It's all in the messaging and the structure.
So just as background from my asking that follow-on question, here in Ontario, we had a problem, or at least I perceive it to be a problem, where in regulation, when we started collecting health workforce data from colleges, we put some of the uses right into the regulations. And that ended up tying our hands. You know, changing legislation is hard. Changing regulation is not quite as hard, but still hard. And they ended up tying our hands down the road, right? So there's a real question in my mind, that balance between being specific, and the more specific you are, in some sense, the better it is in the short run, but maybe detrimental in the long run. And so getting that balance right, I think that's a real challenge on the legal side, at least within a context like Canada.
Arthur, I will share with you, and I would be happy to share this to the group. Indiana has model language that actually is at the introduction of every single health professions renewal where they provide their supplemental information. And it is specifically vague about the way in which the data shall be used. But it is an example of framing that up so that the hands don't get tied, but it does protect it from proprietary use and those sorts of things.
Yeah, it's sometimes getting that balance right. I don't think we have it quite right in our province, but anyway, anyone else have comments on this topic? Katherine or Tina?
I'll just say I agree with the why, that's so important, and procedures of ethical data holding are important. And I'll just share that we heard that I think it's fair to have a lack of trust in this data, and that's fair to not want to share some of these details, and that we've heard that who holds this data and how they report it is still very much an area of contention, especially regarding race, ethnicity, and Indigenous data sovereignty. So those are contentious problems that were challenges that we're still trying to solve. So I don't think we have the answers for you yet.
Tina, did you have anything you wanted to contribute?
No, I think Hannah and Katherine have spoken and from their experience on ground. I just like to reiterate that the issue is often when you collect data and you don't use it, then you're like, why do you need it then? So if you have an objective and you're collecting the data for the objective and you put it back for policymakers or as a global good at the country or a subnational level, then it makes sense and it can be justified. Then you'll have the backup of your superiors or those who are in places that can mandate that.
Okay, well, thank you. So I think we have Steve and Gail, and I am conscious we only have about 10 minutes left. So I'm going to ask everyone, including myself, to be a bit concise.
I'll be brief. Yeah, just sort of. Steve Slade. I'm the Director of Research at the College of Family Physicians of Canada, and have done a bit of work in this area too, actually trying to gather data from across jurisdictions for physicians in Canada. And I have to say, Tina, I very much agree with your comment about having to make do with what you have, and how you come out and ask people to conform to a data standard. You have to kind of meet people where they are and make do with the data that you get. So some of the messages I've heard. I do wonder, the question I have is about keeping these data standards fresh. You mentioned the 800-pound gorillas, Hannah, and I don't think that data is pretty fully cooked, and it's not changing as much as some of the new professions. We talk about medical scribes and medical assistants. We have personal support workers, and the workforce is changing. It changes rapidly. You talk about gender identity and the way that you describe things, and the categories that might be in a response set are changing frequently. So I do wonder about your thoughts about keeping an MDS fresh, and just in a related way, how do you when you have data providers, how do you signal to them in a constructive and a non-accusatory way that they are not even close? Their data is not even close to a standard, versus others where you might want to say, you don't have to worry about it. Like, you are so far ahead of the pack. I do wonder about sort of the tactics and strategies of providing feedback to data providers that would give them a sense of where they stand in terms of conforming with a minimum data standard. So the question of how do you keep the data standard fresh, and how do you constructively feed back to data providers?
Does someone want to go first on that one?
I could start off. I like the question, especially on the data quality and how do you improve the data quality. So in WHO, it's something we struggle with. Like I said, there are some countries that are really good and they know how many health workers they are. Maybe because they're a small country, some bigger countries too do. What we've historically done is shied away from using the data because it's not good quality data. But then we said, no, we're going to use the data. We're going to show them how bad their data is. And then the countries are going to say, yikes, I can do better. And so unless you use the data, you don't have an incentive to improve the data. I think that's an approach to take. It's not to shy away from what you have, but you use what you have and you show to them that this is not coming through, this is falling back. You need to improve the bar. That's something that's worked for us at WHO, working with our countries and improving DR systems.
Okay, unless someone else has, we're starting to run out of time, and we actually have an increasing number of people online with questions. So I'm just going to move to Gail, if that's okay, unless Katherine or Hannah have something urgent in response to that question.
So thank you very much for your presentation and all the work you've done. But I have to say, I'm just a little bit depressed by some of the stuff you said. So I focus my work, my research. I'm from Canada, by the way. I focus my research on teamwork and collaboration, and we're hearing a lot more about that. Correct me if I'm wrong, but it seems like there's a lot of work that is looking at counting bodies as opposed to roles or clinical contexts or anything that would speak to the idea of collaboration. Do you see anything within the minimum data standards, any data elements that could speak to collaboration, teamwork, how people work? Or is that maybe coming down the road? What do you envision?
I can start first, given that it's specific to Canada, maybe in part. Yes, so some of the details and things that I shared are about counting bodies, and that is some of the information that we have, unfortunately, because we're behind other countries. In the MDS that we're developing, there's a lot of questions on capacity, and it's a part that we're really excited about in terms of what type of work different healthcare workers do and how they spend their time. And I think that would be incredibly important and insightful for collaboration. And so hopefully we're moving towards that direction. And with our MDS, that's our goal, definitely. So hopefully we're moving towards away from just head counts and towards more detailed information for a lot of different healthcare worker groups.
Hannah, did you have anything you wanted to add to that?
I can just add very quickly. I think if you all have access to all of the questions, I dropped a link early on in the first question to Indiana's survey tools, We do not specifically ask about licensees' engagement in care teams, what those care teams are comprised of. But there are questions regarding the specific types of services that they provide, the roles that they serve in, the settings that they are working in, as well as we have statutory authority. So they're reporting a geocodable pinpoint location that they're practicing. Because we have that level of resolution, we are able to look at clusters of licensees that work in the same areas. And so that is the way we're kind of backing into what do the care teams look like and what does collaboration look like. I think for the broader CPMDS, in order for it to be a tool that would be easily acceptable and adoptable by states and by regulators to really minimize burden on licensees. So I want to drive home the tool that I shared with you all today. The top value is top value to a state, minimum necessary burden on licensees, because these are governments collecting this data. And so there was some discussion about interprofessional collaboration and coordination and innovations and new practice models, but the decision was states and jurisdictions that have specific targeted interests in that can focus on collecting that. As a researcher, that hurts my heart, but the reality is there are some very basic questions that states can't even answer right now.
These are meant to be minimum data sets, not maximum data sets. So we have just a few minutes left. Maybe I can ask Ivy, she has all the online questions, to sort of give us a set of questions, and then we'll go to the panel with not just one question, but a few questions.
Absolutely. And I think what we can do is just have each of you, provide a bit of sort of wrap up comments. You've seen the questions and you've answered some of those questions online. Aaron asked about sort of impatient stakeholders and the importance of, they want answers now, but there's a value in investing in the data infrastructure. Niru asked about, looking at leveraging data from non-health sources for workforce planning, which we will get to this afternoon. Andre also asked about some of the legal obstacles to collecting equity, diversity data, and also just about you may have people who are out in front, but they may change their minds later on and restrict data collection and access depending on how it's used. So I know that each of you sort of provided a response, but maybe just use those as points to provide some summary comments. So back to you.
Any of the three of you want to respond to Ivy's sort of collection of questions?
I'm happy to go first, I guess. I think I really appreciate the comment regarding impatient stakeholders, or regarding the fear that your regulatory boards or your state government or whoever's sourcing your data may retract. I think that speaks to how very, very, very important it is to know your audiences, know your stakeholders, and make sure that there is ongoing discussion with them related to the value proposition of the data from their unique vantage point. That can't be a one and done, and now we've got this. It has to be ongoing. And then also I did a response on one of the questions. You need to go for the top dogs. Okay, if you're going to do this through governmental workforce data collection, which means you need governors buy-in, you need legislative buy-in, because once you have those two, you will have all of the rest of the executive branch in line. And so as opposed to maybe, struggling with your boards and trying to make the value proposition to them, let them know they can champion for their governor and for their legislature. That's my greatest advice for individuals that might want to take this back.
Thank you. Tina or Katherine?
Yep, I can go next. I think Hannah's just, tapped it on the head. It's just about getting your governance buy-in. It's one of the first steps in the implementation of a minimum data set. We're calling it the IHWC, but it's the same. You want to strengthen your data, you need the governance buy-in, because without that, you're not going far. Because you go to someone, they say, who said? And you have to say he said or she said, and then you've got your passport to get in the data. So that is key. The legal frameworks are also something we saw that there are bottlenecks in countries that without a proper legal framework on sharing data, things don't happen. That's something that I would also emphasize, that it's something that it's seen or overlooked, but shouldn't. It should be one of the first things to be addressed. The question on non-data sources, NHWA talks about the diversification of data sources. And Neeru, if you're familiar with the work we do, you've been here, we've always said we use census data, LFS data. We use data from the professional registries or World Health Surveys or any DHS. So triangulating the different data sources, we see that with countries who have been systematically providing data from one data source, they realize that they have a better data source, but they never tapped into it. So improving and triangulating your data sources helps to improve the data.
Thank you. Katherine?
All right. So in our experience, many of the people we talk to want to do better and know that they can improve. So that's our status here in a lot of ways. We have a ways to go in Canada, but we do have an opportunity now with increased pressures placed on the need for health workforce planning to make huge leaps. This can include expanding beyond regulatory data and census data. We have the technology, and if we're really concentrating on this now, I think it's a great opportunity. So although I think it was Gail, a previous owner, said it's a bit depressing, part of it's exciting as well, because I think we have this opportunity here to really expand what we do in this country. And I think other countries maybe can relate to that. We can also learn from other countries' experiences. We can look at what Tina's presented, what Hannah has accomplished, and that can help us to move forward faster than we would if we're starting from scratch. So I'll leave with just saying there's a lot to handle in this area, but I'm excited about the future, and I hope others in this room can be too.
Thank you very much. So I think we have to bring this to a close unless the panelists have a last 30-second maximum statement they want to make. I think this has been a great panel, so thank you to the three panelists. I certainly have learned a lot. It's made me think about some of these issues. I hope it has for you as well. And so now we have a break for 15 minutes and we come back at 11:30 to look about interactive health workforce data dashboards. And I hear especially our visitor from Colorado has some amazing things to show us. So I'm looking forward to that. Thank you.